Good morning, everyone. Thank you so much for being here today for our Substance Use Treatment Services Access, Engagement, Treatment, and Recovery training. We're going to give it a couple minutes as I'm doing this intro just to let folks continue to trickle in from the waiting room. But again, thank you so much for being here. My name is Nicole Thomas. If you have not met me before, I'm part of the Homebase team. So Homebase is a technical assistance provider that provides TA support to continuums of care across the country. And in particular, in Santa Clara County, we work really closely with the Office of Supportive Housing and the COC. And one of the many things we do is help organize a suite of trainings on behalf of the Office of Supportive Housing. And we're really excited and lucky to have Tiana and Laura here today to lead this training, and I'll certainly let them introduce themselves momentarily. But before we get started, just want to go over some very basic Zoom logistics with you all. So closed captioning is available. That live transcript function you should be able to get to if you just toggle to the bottom of that menu bar. But if you're having trouble seeing the closed captioning, please just let me know. You can send me a private message through the Zoom chat, and I'd be happy to help you get that. And then you'll notice that we are muting everyone upon entry. That's just to minimize background noise, but certainly when there is a Q&A section, we invite you to bring your voice to the meeting if you would like to and unmute yourself then. But really, we're going to direct you to the chat box as our primary way to read questions you have, see the comments that you have throughout the training. And then, as I said, any tech issues you're having, please feel free to message me directly through the Zoom chat. If you're having trouble with that even, please feel free to email me at nicole@homebasecc.org, and I'll keep my eye on my email to help you through that. So just to have folks feel familiarized with the chat box, we want to have a quick icebreaker. So I'm going to ask that you type into the chat box your name, your organization, and then what was your most memorable birthday and what did you do? So for example, I would type into the chat box that my name's Nicole, I'm from Homebase, and my most memorable birthday is hopefully yet to come. On my 30th birthday, I plan to go to Paris because my birthday is on France's National Liberation Day, on Bastille Day. So I'm going to go to Paris and pretend that the fireworks are just for me. But I am going to look forward to reading your responses. And as I said, we're really, really lucky to have Laura and Tiana be our presenters today. So I'm going to hand it over to them to introduce themselves.
Hi, everybody. My name is Tiana Davido Nelson. And some of you may recognize me. I worked for the county for 35 plus years. And just briefly, I started out fresh out of UC Berkeley needing a job and was working at the public defender's office as a file clerk. That position doesn't even exist anymore in the county. Anyway, kind of worked my way up through the system, became a licensed marriage and family therapist, worked for behavioral health for a very, very long time, went back and did my doctoral work in systems theory and came over to behavioral health quality improvement on the substance use treatment side of the house and retired from that position a couple of years ago when we were actually still in COVID. So I still have a passion for the work I do and lasted 4 weeks in retirement, said, I can't do this. And now I work for Pathway Society. What I went from the dark side to the light side, working for the providers. And I am still passionate and love the work that I do and feel very, very privileged to be working with Pathway Society, which is a network provider on the substance use side that kind of has its own continuum of care. So I will let Laura introduce herself.
Oh, thanks, Tiana. So I am Laura Wendet Al-Qureshi. I have worked for the county since 2002. I started as an intern in the perinatal substance abuse program, and I am now the manager of the program that I did all of my training in. So I've worked in addiction medicine with mostly opioids, some alcohol use disorders. Of course, there's other substances in there too. again, for a very long time. And really, I do miss some direct patient care. However, I also enjoy working with employees and then other staff from contractors or other agencies to help them assess and then refer their patients into addiction medicine treatment. So meaning medication for opioid or alcohol use. So I enjoy helping providers now as well as staff in just a different way. So yes, and I worked with Tiana when she was in QI. I do miss her at QI. I now see her at Pathways or see, yeah. Okay, that's it.
And so just because I forgot to mention two things, I know there are often a lot of questions about this, so I want to preface, the training is recorded. The slide deck, the recording, all of the materials today are going to be shared with you all. You'll receive an email when all of the materials are posted online, and then all of the materials can always be accessed through the COC's training webpage. So that's another way you can access it, but just wanted to let you know, because I know some people are fiercely like writing down notes, trying to get everything on the slide decks. All of that will be shared out with you. And then for today, both of our presenters have a lot of content to cover. So we're gonna definitely be keeping an eye on the chat, but saving Q&A more towards the end. And really encourage you all, just because there is a lot of content to cover, to be focusing your questions on more general substantive content questions. If you have really specific questions that pertain to specific clients, specific cases, we're going to be sharing both presenters' contact information. So you could reach out to them offline, and they said they are available and happy to provide that consultation. But we just want to be mindful and strategic of the time we have together and how we're using that. But I will stop talking and let them continue.
Okay, next slide, please. You've already done all that. Here we go. Okay, so as a disclaimer first, I'm hoping you all can see this when I put this up. Can you see that this little design here?
Yeah, yeah.
Okay, so what we have is, it looks like this is somebody that's kind of in a little jail type setting and is pushing and pushing and pushing one way, but look there's an open door. Can you see that open door?
Yes, yes.
So, okay, sometimes when we start talking about behavioral health services in today's day and age, it can get really frustrating. It can seem like we're pushing and pushing and pushing, and we know that there's an open door, but it's really difficult to get clients in. Whether it's the nature of the beast, the clients not ready, or whether or not services are backed up. So in light of all that, I'm telling everybody, keep that positive attitude, because we do have an array of services, but we're also working in a managed care world now. And what that means is, in the public health system, just like your own health insurance, everything kind of has to be authorized and qualified, and it can become bureaucratic, and it can be really frustrating. But when you have contacts and you network in the system, and I encourage you to use those networks, you can get your clients into that. You can get them into care. It's just sometimes requires a little bit of patience, depending upon the complexity of variables in trying to get them in. So being in a managed care system, which both substance use and mental health now have contracts with the state, what that means is all services have to be medically necessary. So let's say that you have somebody that's experimenting with substances, is a 18-year-old, doesn't really meet the qualifications for a substance use disorder yet, based on the diagnostic criteria that we have to. There are things that are in prevention and services that are out there and resources, but they may not meet going into an outpatient level of care, and certainly wouldn't meet going into a residential level of care. So basically, a client has to meet the medical necessity, and those medical necessity criteria are defined for us by the Diagnostic Statistical Manual, okay, the DSM-5. Some of you may be familiar with that. That's the manual that we use to diagnose. And they also have to meet the American Society of Addiction Medicine criteria, which is a 6-domain assessment that after looking at all those domains like intoxication, their physical health, their mental health, their propensity to relapse, the danger that they might be in their environments, their social, all those factors that you guys are all working with, we put that all together. And the ASAM has what they called a patient matching to a level of care. So that's how we determine which level of care they go into. Next slide, please. So in ASAM, which is state required, okay, DHCS, that's the Department of Health Care Services, requires that the state of California, all counties have to use this ASAM criteria, okay? And with the ASAM criteria, there are multiple levels of care, and each county has a contract, a separate contract with the state DHCS that determines what levels of care they must provide. These are county-based services. And in Santa Clara County, about 75% of those services are contracted out to providers. So for instance, Pathway Society, we contract with the county to provide certain level of care, substance use type services. This continuum gives you an idea of what those services are. And it starts out at early prevention, which we have a referral base to. We have outpatient that we're required to provide, intensive outpatient for both youth and for adults. We have partial hospitalization. We are not required to provide that, but Santa Clara County did provide that for many years through Caminar. And I think if you hit it again, it'll show the continuum. It should show more. There you go. And then we have different levels of residential that we provide. And the residential levels of care are based on intensity. So 3.1, you might have somebody that has really, really serious substance use, but maybe their mental health issues are not as prominent. 3.3 is a special population that we can treat, usually requires more individualized care, and they usually have some cognitive impairment, whether it's due to brain injury or whether it's due to substance use over the years. And then we have 3.5, which is a highest level that we provide of residential services. And those clients generally have what we call, for lack of better words, in pathological terms, comorbidity, meaning they have a serious substance use issue, and then they have a moderate to severe mental health issue as well. And that doesn't include the host of social factors that you all know that they have. That could be homelessness, joblessness, family problems. I mean, there's a whole host of social determinants that may qualify them to go in any one of these levels of care as well. Then we have a separate area called withdrawal management services. This may be, to some of you that have been in the system for a while, this used to be called detoxification. They changed the language to be more consumer friendly as withdrawal management services. This is more like a stabilization type services. There are 5 levels of withdrawal management services, but Santa Clara County and most of the other counties are only required to provide 1. And that is called 3.2, which is a non-medical clinical service. And I'll go a little bit more into depth what that looks like a little bit later. Next slide, please. The state now, with some of the reforms that they are providing in our government contract with them, also provides a level of care called recovery services. You may have clients that haven't used substances for a period of time, and they meet the criteria for a partial remission or a full remission diagnosis, but they still want the support. The state created a level that's kind of like an aftercare called recovery services, and they still have a medical necessity requirement, but they have to have that diagnosis of being in partial remission or full remission. And then they can receive those recovery services for as long as they need them. The state has put no restrictions on that because they want people to stay in aftercare if that's supporting their sobriety. Next slide, please. I was talking a little bit about withdrawal management. Santa Clara County has 28 current beds for 3.2 level of care. This is something that the Board of Supervisors is currently looking at to improve, I think by about 15 to 20 beds. And I know they were looking at for youth, although ASAM doesn't have withdrawal management for youth. So that's something that Santa Clara County is having discussions around right now. They've consulted me. That's how I know that, even though I don't work for the county anymore. But we do have other types of withdrawal services that are needed and more serious. Those are considered 3.7 and 4.0. The county's required to have access to them, but we don't have to have a provider that specifically is contracted to provide them. Those level services are very serious. The 3.7 and 4.0 are those clients that come in that use multiple substances where they physically withdraw, that they can have seizures where it's affecting another of their physical health conditions like their hypertension or their diabetes, or they can fatally overdose. So substances such as heroin, fentanyl, Percocet, severe alcoholism. These are all substances that may require what they call medical monitoring, where you have medical professionals around the clock. Medication is given to the patient, and then they're monitoring them as they're coming off the substances. There's a 72-hour frame, and this mostly happens right now in the hospital, that they keep them to make sure that they won't have those seizures or go into overdose. Next slide, please. Okay, what types of services do we provide in our substance use continuum of care? Just much like the mental health side of the house, we have individual counseling that has an array of services. These services are all bundled, so they don't, even though we would do a crisis intervention, it's just called individual. We do assessment, and every beneficiary is, they can have an assessment. So if you have somebody that you're not sure whether they meet the criteria for a substance use, you can actually refer them to get that assessment. It is part of their benefit as a Medi-Cal patient. If they are unsponsored and they don't have insurance, we also take those clients in the system of care. They also can get that assessment free of cost to them, okay? And then the providers will look at that matched level of care to see what diagnostic criteria they meet. And then depending upon what criteria they meet, there's different services that are provided. But in the individual counseling and outpatient, they provide group counseling, and they also provide a high level of case management. So the county is recently transferring a lot of these higher risk, high utilization individuals into something called ECM providers, which are enhanced care management. But even if they come to us in substance use and we recognize that, we can refer them. So you can refer them to ECM, we can refer them to ECM, and ECM is a hub and spoke system that's done through Santa Clara Family Health Plan that helps them to get the array of services that they may need, including extra resources to housing, which we all know is a huge problem. So think of this picture when you're thinking of housing in Santa Clara County, because it's a national phenomenon. It's not just in Santa Clara County, but we do have a very serious problem with that. And we know that with our behavioral health clients. One of the other services that provided that Laura is going to go into in depth in a little bit is medication assisted treatment. And there's different types of medication assisted treatment that she'll describe. If you want to talk a little bit about it now, Laura, you can, or we can go to the next slide and you can talk about it in your other slides.
Sure. I can just give a brief overview. So medication assisted treatment generally is, when you talk about that, those three MAT, it will be buprenorphine, also called Suboxone or Subutex, methadone, or Vivitrol, which is injectable naltrexone. So the clinics that I manage, there's 3 clinics, 2 programs. Those are the main medications that are dispensed from those clinics. There are other medications for alcohol that we also prescribe, but those are the main three. And then the perinatal substance abuse program will treat women who are parenting, who are gaining custody of their children, or who are pregnant, who have a substance use disorder. So that's briefly it. So back to you, Tiana.
There's a question if Sublocade is offered
Sublocade.
as well.
You know, we're in the process of starting Sublocade. So Sublocade is a monthly injection that is basically long-acting buprenorphine. So we do have patients on, so buprenorphine is a daily medication. Unless it's Sublocade, then it's a monthly injection. Same as Vivitrol. Vivitrol is a monthly injection. But so Sublocade is just changing the formulation. So we do have patients on prescription buprenorphine. They still take it daily. But yes, Sublocade, I know the jail was doing it upon discharge, and then patients were following up with us. So I know the physicians did have a training about using Sublocade. It was, I don't know, a few weeks ago. So it is coming to our clinics is the short answer.
And
Yes.
then the longer answer to that is it is offered at reentry.
Yes.
Reentry is there are some hub and spoke programs that
Mhm.
are doing that are part of the county services. But remember, reentry is a bridge service. So reentry is providing services until those clients can get into a treatment program where they're having continued services, either through substance use treatment or behavioral health. So even at reentry, which has been a great bridge service, they will prescribe sometimes psychotropic medication for our mental health patients. But the expectation is that the county will get them into a provider where they can have ongoing psychiatric services, ongoing case management services through behavioral health, and ongoing therapy.
And then I think, also with anything that is an injectable, so some patients are more open to something like Sublocade or Vivitrol. Some patients just want the oral medication, and that would be buprenorphine, or naltrexone, which would be the option for people who don't want the injectable Vivitrol. So, yeah.
Okay, next slide, please. Okay, so we're still talking about COVID-19. And so during COVID-19, there were a reduction of services. There was for a number of reasons. First of all, staff were getting sick, clients were getting sick, in enclosed facilities such as SNFs, recovery residences, THUs, board and cares, and residential treatment facilities. They had to meet a social distancing standard. They had to restructure. So there was a number of different services that were affecting those enclosed facilities for reduced services. In outpatient, same thing, with shelter in place until that was lifted and the vaccination came. They reduced all face-to-face services. Now that we're coming out of that, we've got several boosters. What they found with telehealth is that several clients preferred to have telehealth services. So now most providers offer what we call a hybrid. And the inpatient services that I know, residential treatment services, they are back to full capacity and running now. So that's because of vaccinations. But this is all recent. These services slowly had to rebuild up. They had to get staff again. And what we're noticing now is that there's been another surge in COVID. So programs are just very cautious because we can't control people that are coming in and out of our programs, where they are, whether they're masking, whether they're taking care of themselves. Same thing with staff, right? We don't know. They may wear their masks when they're in the facility, but when they go home, we don't know who they're engaging with. So there are very strict protocols that are still in place around masking, but the access is back to where it was with capacity. The other thing that we're noticing about the impact on services, both outpatient and residential, is trauma. Many families experienced loss with COVID, whether it was due to COVID or comorbid situations, stress. We've seen more ODs. We've seen an increase in alcohol use. We've seen an increase in opiate use. So we know that some of that is directly contributed to the impact of the pandemic on both individuals' physical health and on their mental health. So interesting. We're seeing since March 22, a surge in our referrals in outpatient to the point, and so is behavioral health, to the point where they are at capacity. And many of them are waitlisted to try to get in, or we're having to refer. So here's an example. Pathway, we have a certain amount of slots of capacity. We have been 10 people over that capacity for about 4 months now. So we're working with another provider called Health Right 360 to directly hand off those clients to make sure that they're getting the services that they need, because we don't have any more staff to see them. We already have over the capacity. And I'm noticing from my conversations with several people on the behavioral health side, our sister in the mental health side, they're experiencing the same thing. Some of the things that are listed here, I won't read the slide to you. We are trying to work with clients that have limitations to technology. One of our residential programs will go and get clients phones so that they can transition from their residential program to their outpatient and have a way of communicating. We are also creating spaces in our providers to have Zoom or virtual sessions where people feel safer having a Zoom session rather than having it face-to-face. So there are a lot of creative ideas with multiple providers to offer a different method of delivery depending upon what the client's comfortable with. Next slide, please. So I wanted to talk a little bit just about residential treatment, because a lot of people feel that residential treatment is very difficult to get into. It really just depends on the program. We have perinatal services that right now referrals are low to, but the perinatal services that are provided for residential, it's for women with their children that are pregnant or have children that are under the age of 5. And they have a certain length of stay that they can stay in that program past postpartum. If they have a child, that's 60 days that the state allows them to contract. So technically from the time of conception all the way to postpartum, 60 days, they can stay in that program. And I'm pretty sure that the state would not send somebody to the street if that woman was still struggling with sobriety issues. In terms of women with their children, there are separate contracts. Some of those are with social services. And so the perinatal services and beds are done through social services. So sometimes you may have a client that has a social worker or that's going to court, to wellness court, that can access perinatal services that way. The other residential programs that I described before, there is a program for youth. Right now, the county's program for youth is being restructured. It's Advent. And so they are sending youth to the camp over in Santa Cruz while the restructuring is going on for Advent. But Advent is who they normally go to, which is in South San Jose. And they have houses in 3 different areas for both males and females. And for the adults, there are 2 separate residential programs. Pathway House is one of them, and Telecare is the other. Telecare sees a lot of what they call AB 109. So if you have criminally justice involved clients, a lot of the clients get referred up to Telecare for that. But Pathway can also take AB 109 clients. So we work very closely with the court to meet the requirements that the court is requesting of us. But what we don't do is we don't UA in our programs for them. We leave that to probation, because that is something that the client themselves works with their probation officer to provide. We only UA for self-efficacy in working with clients around what we can do to help them reduce their baseline, or if they slip or relapse while they're in residential, which can happen if they go out on an appointment or something, then we want to continue to work with them. We know they're in the right place if we see that happening. But all of those clients that come in have to meet these criteria. They have to be medically eligible. That means they can't have a medical condition that prevents them from participating in treatment. A question might be, what might that be? Somebody that has to go to dialysis 4 times a week. I know this because my son's pending a kidney transplant. There's no way he could come into residential treatment. He's in dialysis 3 times a week for 4 hours in those 3 times. That's a significant chunk of time. And then he's weak and he's sick often after dialysis. So he can't participate in that level of intensive programming of residential. So those individuals, we would offer either in-home services or an outpatient level of care that works around their dialysis schedule. Medical necessity just means they have to meet probably a severe diagnosis, longstanding use, daily use of methamphetamine, daily use of heroin, multiple polysubstance use for years. So they have to meet that criteria, and then they have to be clinically appropriate. And what that means is, let's say that you have somebody who is, for lack of better words, overtly or fluidly psychotic. If they are responding internally and are not redirectable and need their mental health to be stabilized, we work with our mental health partners to have them first go to either crisis residential, crisis stabilization, or maybe even EPS if we think it's something that's meth induced, to get a medication to help them with treating those mental health symptoms, and then they can come into residential. So there's a lot of criteria that has to be met. And the only reason for that is because we want the clients to be able to benefit from the treatment. If they can't engage in treatment, it's a disservice to them, to be in a program to bounce them back and forth when they need to be stabilized in other areas first. Next slide, please. And I've already discussed a little bit about the residential services and the high intensity versus the lower intensity of 3.1. We're required to provide in a 24-hour structure 20 service activities a week. The state defines what a clinical service is, and then they define what a service activity is. What that means is that if a client has a mental health appointment, or they have a medical appointment with their primary care physician, or they may have a case manager appointment with their housing case manager, the state allows us to do the case management and work with these other providers so that the person can stay in our residential setting and still meet the required clinical service hours. But I will tell you that at Pathway Society, both at the Pathway House and at Mariposa for women, we do well over 20 clinical service hours a week. I want to make one comment about the withdrawal management services. It's very important that you understand, if you're helping a client to get into withdrawal management, that we have a phone screening. That and Pathway right now has what I would call pretty much a monopoly of the withdrawal management beds, because Telecare only has 2 beds. So they're looking to expand these services, but it may not be appropriate for a client to come in, as I mentioned before, if they need to be medically monitored. So what we do with clients in that phone screening is we let them know what the resources are and where they need to go. Now, if somebody comes in and they say, the last time I was in withdrawal management, the doctor prescribed me Librium to help me withdraw safely. We have a level of certification in the Pathway program called IMS, which is Incidental Medical Services, which gives us just a little bit of wiggle room where we can give them some Librium and we can take them in. We can give them a little bit of Ativan to help them withdraw from alcohol. Mm-hmm. However, it is a medical decision whether that happens, and the doctors will work with the hospital doctors if they feel that client really needs to go in and be medically monitored because they have a history of seizures, or they've had a history of OD, needing Narcan to help revive them. So there's a number of complex issues and variables that happen right when that first phone call, so that we can get the client in the appropriate level of withdrawal management services. Next slide, please. Okay. So this was, I've already described this, but this has also changed a little bit since the vaccination. Initially, residential programs were not taking unvaccinated clients because we we did not want to mix those populations of vaccinated people and unvaccinated, but then we worked with the county for ways that we could have sequestering in the programs in case somebody got sick, without, not saying that, hey, it's your choice whether you want the vaccination or not. And now what we've done is we've partnered with the COVID hotel. Thank goodness that hotel still exists, because we just had an outbreak over in our withdrawal management program, but there was like 5 clients and 3 staff. They all got COVID. Don't know why. We think that one of the unvaccinated clients that went out on a hospital visit may have brought that back in, and we test, but it can incubate over 3 to 5 days. So we just take strong precautions. So one of the things that we'll tell you if you're referring somebody to a residential program, and even if it's crisis residential or substance use residential or to withdrawal management, is, hey, if you can get a COVID test within those 24 hours and let us know, they're going to get in faster, because we know that we can bring them in and they won't expose the other people that are in that, that same setting. Next slide, please. Okay, what does this mean? Such ancillary services. So what that means is, in the continuum of care, we recognize that a lot of people that come in with substance use issues have other issues that need to be addressed. So what we are permitted to do is provide what we call bridge services. So those providers that don't have a mental health contract, they can provide bridge mental health services with what they call a licensed professional of the healing arts. And the state defines a licensed professional of the healing arts, somebody that is an associate MFT or an associate social worker or licensed social worker, psychologist, intern psychologist, people that can provide therapy essentially and can diagnose in the DSM. They can provide a bridge to get somebody into psychiatric services. We can provide non-emergency services. Anything that would be an emergency service would be something that would go directly to the ER or the ED or to emergency psychiatric services. But if they're non-emergency, then we can provide crisis intervention. We can still do face-to-face. I talked about that. Or we can Pathway actually got grants to increase their telehealth and computers so that we could have clients at our recovery residences to support them in getting their outpatient services. And what that means is a recovery residence is the same name for a transitional housing unit that's a sober living environment. The housing unit itself is temporary housing up to 90 days with extensions if the client is still in treatment. So I know I actually have a client who just got her 1-year sobriety. She's a fentanyl and heroin user. She got 1 year sober yesterday. She's been in her recovery residence. She was 90 days in treatment and then however many months minus. I'm not going to do the math, but she's been in her recovery residence that whole time because she's still actively going to her outpatient treatment, and she's getting ready to transition now with a remission diagnosis over into recovery services. So that way there's no gap in their care and they can stay in a sober living environment which supports them. Whereas their other environments, if they're returning to homeless encampments, we all know that those are dangerous environments where there's a lot of drugs and alcohol that are passed around, or even their homes or apartments that they might be returning to may be environments where there's easy access to substances or their partners may be still using. So we really encourage the use of the ancillary housing services to those clients that go into outpatient so they can live in a sober living environment. And I already talked about COVID-19 impact and we now take clients that whether they're vaccinated or not, and we have Wi-Fi and telehealth in all the recovery residences for those clients that are still uncomfortable doing face-to-face services. Next slide, please.
Tiana, you had mentioned the previous slide that having a negative COVID test could expedite the process. And so there was a question in the chat
Yes.
whether home tests count.
No, it has to be a PCR. I'm so sorry. It has to be a PCR. And that's not just a Pathway requirement. Any service that you go to, the crisis residential, crisis stabilization. I know this because I refer sometimes when somebody comes in appropriately to us, we'll work with them. We don't want to send them back to the street, so we'll keep them in our withdrawal management program. They'll even say, hey, we need your most recent PCR So they want a PCR test.
And I also want to say around just really quickly, as far as patients needing a medical clearance. So why is that? So if they are alcohol dependent, they could have a seizure in a residential facility and have a very, very serious medical consequence. So if a patient is dependent on alcohol, in our services, we want them to be able to, go to Be Safe and attend services. And that may mean that they need medication, like Tiana said. Usually it's Valium, Ativan, sometimes there's a Librium taper, but that is really to protect the brain of the patient so they don't have a seizure in a residential setting, because residential is not hospital, right? So that they don't become worse while they're not drinking. So that's the reason around alcohol to have a medical clearance. If it's an opioid situation and they need a medical clearance, it is because they have another medical situation, another underlying, they may have a heart problem, they may have some, usually we see high blood pressure, or we see that needs a clearance. Or we see if it's pregnancy, we need, if the patient has a seizure disorder, they need clearance, they need medication for that. So it's fairly serious, when you're talking about medical safety, even if the patient has a long history of drinking or using, they still may have something, life-threatening happen in another level of care, and we don't want that to happen. So it's kind of my feedback on the alcohol or opioid stuff.
And our staff, I've seen it firsthand. I've been on site when we've had somebody have a seizure, and thank goodness where we are, 911 services they're very quick to respond to us at Mariposa and over at the Pathway Houses downtown. So we've been very fortunate. We've had to Narcan individuals, and hearing about our clients when the paramedics have come and taken them away, they've had to Narcan them again. So it doesn't happen frequently because we try to get that up front, that medical clearance up front, and really work with that, because it's very, very complex. Somebody could be drinking and have never had a seizure, and then all of a sudden that's their time, and then they have their first seizure with us. So this is why it's important to understand, as you know, our clients are complex. They have social determinants, medical determinants, mental health determinants. It's not just substance use. So we have to look at all of that and the multiple variables that affect them. That's kind of a nice leeway into this next slide. How do you get somebody in? Let's say you've already engaged that client. You've been using your motivational interviewing skills. You really think they're ready to go. The county has a system where you still call the call center. It is now an integrated call center. They want to talk to the client so that they can screen them and get them to the appropriate matched level of care. It's a mini version of that ASAM. And if somebody has been using consistently up until the point that they're talking to them, they're going to say withdrawal management. If somebody hasn't used in a few days, it's an off and on or a binge pattern of use, then they're going to see how long that's been happening, how many out of 30 days, they may say residential. And then most clients, believe it or not, want to start at outpatient. They don't want to go into the highest level of intensive care. And that's okay, because once they get to outpatient, if the outpatient clinician assesses them, and those assessments are all reviewed by an LPHA, a licensed professional that can diagnose, they can always bump them up to get authorization for residential treatment. And we see it from all avenues. So I don't want to say though, if you're with a client and you happen to be on Tully, you can still walk into Health Right 360 and say, hey, can we get an appointment? Okay. Health Right 360 will then work to coordinate with you and your client, to get into the appropriate level of care, even if that means sitting down and calling Gateway. They're relooking at Gateway right now and going into the various levels of care. So I really want to encourage you, when you have a client that is ready If you have them and can call them at that moment, you may have to wait a little bit on hold, but keep them motivated to go, because they will give you an appointment that actual day when you call. And sometimes they'll even three-way you to a provider. If you say, hey, my client's homeless, they really want this or that. The other thing that I want to stress, there are other avenues. This is a little complex as you look at the continuum of care for entry. So we may have somebody that's in a recovery residence that is relapsing all the time. So their outpatient provider would then say, oh, let's bump them up to residential. We may have somebody that's in residential that says, hey, they've completed all the treatment plan goals. We then will bump them down to outpatient. So there's multiple points of access, but the best way to get in is to call that call center and get that screening done. The only other, and I think it's the next slide, that I can share with you is our withdrawal management services. Either one of these numbers can be called. Those are client access lines to get into withdrawal management. These lines are for Pathway House. I believe that Telecare withdrawal management goes through the county, but you can access these phone lines to get somebody into withdrawal management services directly. What'll happen is there's an admissions coordinator that will do the phone screening right then and there and tell the client what they need to come in. At Pathway House, at that phone screening, they will let them know once the doctor has reviewed that phone screening, they're going to get an actual intake appointment. And so that the admissions coordinator will work really closely. We have one client right now that has no phone. She calls every single day with her. We assessed her. She calls every single day with her case manager, goes to that office. We're trying to get her back into her court. She's been incompetent. And so they want to put her back into that wellness court, that mental health court. And Pathway LPHA made a connection with her and was able to direct her back to the court. So even if somebody comes into us inappropriately, we're going to try to get them to the appropriate level of care. Next slide, please. Okay, and these are some of the other satellite assessment sites. So I already mentioned drug treatment court. We have people that are actually in the jail that assess and refer. Dependency treatment court refers. At Laura's shop, they have a perinatal outpatient program. They get a lot of those clients. We have withdrawal management sites in addition to ours, which I share with you is at Telecare. We get referrals from primary care clinics and hospitals. We also get them directly from Crisis Residential. So if you have a client that's going to Crisis Residential first, and you're working with the case manager at Crisis Residential, all you need to do is sit down with that multidisciplinary team, say, hey, I think this client would benefit from residential. They'll contact us, and then someone like myself or another LPHA will assess to see whether or not that client's ready after leaving Crisis Residential to come into our residential, so that there's no gap, so that they're not going back out to the street, for lack of better words. And then very valuable resource, Reentry, the Resource Center that does a number of different services, including mental health, psychiatric, physical health, and then substance use referral. Next slide, please. So I don't know how we are on time. So I'm thinking we're getting a little bit close. We can do this, Laura. This is kind of fun. And normally if we're doing this face-to-face, it's kind of fun to just ask a few questions about some drug facts. So I don't know, I can't see anybody. Is this something that you want to go through, or should we just go on to Laura speaking about MAT? What do you guys want to do? The answers are all in here. You can take a stab.
Yeah, you can see, yeah.
Maybe we could get just like a thumbs up if you want to do some myth busting. And you can get to that by the toolbar, hitting more, and then under reactions, you should be able to see. Okay, I'm seeing 5. Okay, I'm seeing more thumbs up. So I think we could do a couple at least.
Okay. So let's just throw them out there. I know you all can read. So let's start with the first one. Everybody knows that medicinal marijuana is out there, recreational marijuana, that a lot of laws have changed in a lot of different states. So because of all these changes, true or false, it must be proven to be less harmful.
Well, I want to say something briefly about marijuana use. I had a patient, early 20s, no other medical conditions, but very, very severe use of marijuana. He wanted to stop using. He went into residential. I told him, now you might have a little bit of anxiety when you go in. You might not feel real well when you stop. So he decided that he was having a heart attack while he was in residential. They took him to the emergency department. He was not having a heart attack. He was having increased anxiety, and he was having frequent panic attacks because of stopping marijuana. So that experience where, he thought he was going to die, i.e. he had a panic attack, did help him stop using marijuana. So it was he had a very serious consequence. I mean, not life-threatening, but just emotionally to kind of to put himself through that. So yes, marijuana is harmful.
Everyone who did answer in the chat said false. So
That's good to hear. That's good to hear.
Yes.
So even, and so having raised 3 boys in the era of vaping, they will always come to me and say, hey, you're vaping this or that. I said, what about the effects on the brain?
Mm-hmm.
Okay. So basically what you're telling me is you may not have as many carcinogens because you're not rolling up a blunt. I said, but you think that the effects on the brain are different? Or when you get behind a car and you're laughing up a storm and you miss the stop sign, so we've had these conversations, but so you are absolutely correct. That is false. Okay. What about this one? It is worse to inject heroin than to smoke it.
Well, neither are good, right? Yeah.
What do you think, Laura? Most answers I'm seeing are false.
I know. Yes. Everybody's got it. Yes.
Yay. That's good.
Yeah.
A lot of times people will say, well, wait a second, all the complications from intravenous drug use and the communicable diseases and the abscesses and all of that. There are just as many problems with the immune system for people that smoke heroin and the effects on the brain as there are for intravenous drug use. So very good. Yay. What about this one? Ecstasy is just a different form of methamphetamine.
Yep. Everybody's saying false.
Okay. Whoever said true
True.
is correct.
Yes.
MDMA, the MA in MDMA is methamphetamine. I would go into the chemical structure because I'm a total nerd, but we don't have time to do that here. Okay. Not all drugs are addicting.
Well, and I also want to say patients who use methamphetamine, what is a very common mental health co-occurring diagnosis, right? ADD or ADHD. And what psych drug is very similar, it's not habit forming and it's pharmaceutical, is similar to the chemical structure of methamphetamine? Wellbutrin. No, not Adderall's also a stimulant.
Yeah, 5 amphetamine salts in Adderall.
Yes, but if you're looking at the chemical molecule, the similarities between methamphetamine, it is very close to Wellbutrin, and those patients that have ADD, ADHD, many do, and may not be able to take a stimulant medication like Adderall or Ritalin. So Wellbutrin, I know there's Strattera too, but Wellbutrin does seem to help. It's also sold as bupropion to help with smoking cessation. And I will say it does help patients with smoking cessation. And I have seen it also be useful with ADD, ADHD symptoms. The patient cannot have a seizure disorder. So, I mean, they need to see a psychiatrist, but I'm saying there are pharmaceuticals that some are used off label, some for certain things, right? Neurontin, or what is it? Not Neurontin. Trazodone now is very commonly prescribed for sleep. And it is a psychiatric medication. So.
Thanks, Laura. So not all drugs are addicting. So this is a trick question. So that really depends upon your definition of addiction. But if you are following NIDA, N-I-D-A, the National Institute of Drug Abuse, or you are following SAMHSA, they will give you a description of addiction that's now with, it's hard to believe I'm this old, that SPECT and PECT scans have come in, where we now have the brain research to show that addiction has to do with the reward center of the brain. And so carrots actually have the potential to be addicting. So I just want you to know that right now, pumpkin cheesecake is really addicting to me. Anyway, so sometimes people will say it's about an attitude around addiction. And if that works and somebody gets sober, go with it.
Yeah.
But the potential for addiction happens with all substances. Drug addiction is not a mental illness. True or false?
It is.
Yay,
Yeah.
this is
Yes,
awesome.
is,
It
yes.
absolutely is in the DSM-5. So for those of you that have had any, I mean, I've been doing substance use treatment now for over 20 years or been in the field. And it's like, how come we can't get the same amount of money that people do for mental health? You know, that there's still that disparity because people think, oh no, they can stop, you know, and that's not it. There's DSM criteria for a reason, and it affects people with many similar mental health symptoms that we see. So we can probably go to the next slide. And I'm sorry we didn't do more of these, but it's a little fun thing, you know, fun facts.
There
Next
was
slide
a
to give the
question
answers. Yeah.
on if there's a universal definition of drug.
Well, it's a
That's a good
substance that's not
question.
food. It's a substance that's not food. It is a good question.
Yes. So
To
it
treat.
depends upon who you're asking that question to. So we also know there are psychotropic drugs. We know that over-the-counter drugs.
Aspirin
So
is a drug.
and I don't know if you noticed, but for those of you who've been as old as I am, our department used to be called the Department of Alcohol and Drug Services.
Yeah.
Now it's called Substance Use Treatment Services. Hi, Xenia. I saw that. Oh my gosh. Anyway, so very good question. It really depends upon the authority that you're citing. So look at the FDA. Okay, they have approval of different drugs. So anyway, somebody has a raised hand. I can't see the name, sorry.
That would be Mike Eckhart. If addiction is considered a mental health criteria, why do people or entities like Social Security or even the military, why do they not recognize it for treatable substances?
Hey, can I take you with me to Washington to lobby?
Yeah. Yeah.
I'm 100% in agreement with you. And, you know, I would love to have a conversation with you about this. And anybody, I mean, my number, you can email me. The Parity Act has a lot of work to be done. We are still, gosh, I don't even want to use the metaphor of stepchild because I have a stepchild and I love that child like that child is my own. But in substance use, you're absolutely correct. They're discriminated against with Social Security. And I'm just going to say it's because they're behind the times. Anybody that's a nerd like me, that's up on the latest research, whose email gets all the latest stuff that's out there, the different schools of thought, who's arguing what. We all say that this parity is still disparaging against substance use, and it's still treated as something that has negative stigma. We know with mental health that there has been negative stigma attached to that as well. And we've had to overcome a lot of that, but it's still with the legal or illegal components of substance use. It's still treated very poorly, but I'm in 100% agreement with you. And I've had people actually ask me as a practitioner if I could write something. And I said, well, we might be able to do something about your bipolar, but I can't include your substance use because they'll deny you.
Yes.
So, very good. Love that question. And I want to take you with me to Washington to lobby. Accessing the call center. We've already talked about that. We wanted to make sure there, you'll see this number out there a lot. When you call this number, it might take you to what they call the call center now, because they've integrated it in Santa Clara County since I've retired. But they will do what they call an IST, which is an integrated screening tool that's been approved by the state. And then they'll help direct. Does this person go mental health first? Does this person go substance use first? What does this person want? What's their preferred choice? And all of that will be included. So I often see ISTs that say client meets the criteria for withdrawal management, is declining and wants residential. What they have to be aware of is if they come up and we make them an appointment for residential and they're under the influence, they can't come in. They can't come into residential. They need to go to withdrawal management first because we need to monitor them to make sure that they're coming off the substances safely. That's it. It's all about safety for them, safety for the other residents, safety for the staff. But really in withdrawal management, it's all about stabilization, evaluation, and fostering them into care. And if I sound like a SAMHSA promoter, those are directly from SAMHSA.
Okay, so now we're into medication-assisted treatment. So I'm going to talk about methadone. So if you see something that says NTP, that stands for Narcotic Treatment Program. There are very specific regulations around that. So all during COVID, all patients who wanted an assessment and to be admitted to methadone or to the NTP had to be seen in person. We did not close. The doctors continued to see people to medically assess them because they had to do a physical exam. So we did do phone sessions for counseling on occasion, depending on how impaired the patient was or what else was going on. But this whole entire time, all of our physicians and staff has been in the office most of the time. We did do some rotation, but nursing staff, it's a daily medication, so nurses were there every day of the year. So NTP, Narcotic Treatment Program, that means methadone. It may mean buprenorphine, also called Suboxone, or Subutex. Subutex does not have naloxone in it. It is used for pregnant patients. If it is dispensed out of our clinic daily, then it is in the NTP. If it is a prescription, then it would also be considered under medication-assisted treatment, MAT. Most of the patients that we're serving at our 3 sites are are coming to the clinic daily, or they're coming to the clinic somewhere between 1 and 7 days a week, depending on how stable they are. Okay, so the next slide. So I do want to say too, if you have a patient who is pregnant and drinking alcohol, that patient needs to go to the emergency department if they are under 7 months, roughly. If they are over 7 months pregnant, they need to go to labor and delivery. That is not an outpatient situation. That is not somebody who's drinking and who is pregnant is going to need some sort of medical intervention. So We have had patients that we directly sent to the hospital who were pregnant and drinking, because it really was a misreferral. So that is, a dangerous situation for the patient and the pregnancy. So, okay. Methadone's been around for, I don't know, 40 years, long time. It is an agonist, which means it fills up the receptors. The patient should, when they're at the right dose, should not feel any feelings of high if they use opiate on top of that. I will just say, with fentanyl in the mix now, okay, in order to admit somebody to methadone or buprenorphine, they have to be in withdrawal. Because fentanyl is long acting, we'll have patients that will come into the clinic and will not be in withdrawal for at least a day. We cannot admit them. Why is that, right? Risk of overdose and death. So with heroin, basically, if somebody used at midnight, they would be in withdrawal by 6, 7, 8 a.m. We could start them. Fentanyl has really been a game changer, has been just very, very difficult. It's best if the patient using fentanyl can start at a higher level of care, can start at residential, and then come to our clinic when they are in withdrawal. So anybody that we cannot admit, we do give them information, because our clinic is, we basically start at 6, we end at, we stop dosing at 12:30. So the clinic's open after that. But patients are sent to the emergency department where they may be started on Suboxone if we cannot admit them. There is always another option if a patient is wanting opioid use disorder medication, which at this point is VMC. So we've been successful. If we can't admit the patient, they do go into the ED, and then they're started, and then we pick them up. So that, I would say, has probably been our most successful program, is partnering with the hospital for that. Okay, so Vivitrol, all it is injectable naltrexone. Naltrexone has also been around for a long, long time. The patient can drink past the Vivitrol or the naltrexone. They can. Ideally, they have less cravings for alcohol or opioids while they're on the medication. So we have had success. So Vivitrol is a monthly injection. Dr. Singh has been working with this medication for years. I want to say well over 5 years, probably closer to 10. It's been on the market a long time. To me, it appears to be safe, just like buprenorphine is safe. There's more freedom with buprenorphine because primary care can prescribe it if they're willing. Let's see, what's on the next slide. I would say none of these. Oh, this is my favorite. Yeah. So yes, you have, this is my best friend. She's diabetic, she continues to eat food she's not supposed to eat as a diabetic. She's insulin dependent. And, I'm not going to tell her diabetes is a moral failing. I mean, should she stop eating sugar? Yes. So I just kind of offer this to destigmatize any of the opiate use disorder or alcohol use disorder in patients that use medication as an appropriate support. Okay, so next slide. Oh yeah, so you can read this. I don't need to read this to you. So as far as patients getting on methadone from an addiction medicine doctor in our county, in our clinic, they have pain. I am not going to deny that. But the primary diagnosis is an opioid use disorder, meaning they have not taken opioids in a responsible way. So the methadone doses for pain usually stop at 30, roughly, maybe 10, 3 times a day. So that is a pain dose. most of our patients who have an opioid use disorder on methadone stabilize somewhere between 80 and 120 milligrams per day. So the diagnosis on the patient's record will be an opioid use disorder if we admit them to methadone or buprenorphine. Yes, so I would encourage, you to call myself or one of the doctors if you have questions about referring a patient. Patients do have to call Gateway, or the hospital refers. I mean, there's a whole list of how people get referred. Gateway is the easiest option. If the patient, I mean, I know their life may be chaotic. Let's say they miss their 8 a.m. appointment on Monday. It's really okay. They can walk in on another day within the first 30 days of the referral, and we will still try to see them. And if it's after 30 days, all they have to do is call Gateway again, and they just update the referral. So we're admitting patients. I mean, I think we had 3 or 4 this morning, but that were being assessed. And so any referral to our addiction medicine clinic, it is for an assessment. So I don't know, I can't tell you necessarily what medication will be offered. I mean, if it's an alcohol use problem, it's obviously not going to be methadone or buprenorphine, but the referral is for an assessment. And then these are voluntary medications, right? So the physician will come up with what they think is the best medication and then the best course of treatment. And then counselors, nursing coordinate care beyond that. Okay, so what's next? Yeah, okay, so this is just about Vivitrol and buprenorphine. I would say I've seen a lot of success with buprenorphine. Also seen patients, we can refer them outside of our clinic at some point if they move or change locations much easier than we can with methadone. There just are less methadone clinics. It's methadone's really very, very heavily regulated. There's probably 5 different auditing bodies that review our charts and our dispensing activity. So, okay, next, yeah, methadone, yeah, liquid. From our clinic, it's a liquid. From a pain doctor, it's a pill. Yes, buprenorphine. There's also Zubsolv, which I believe is the generic formulation of buprenorphine. It is, yes, abrupt. Yeah, you can't stop either methadone or buprenorphine quickly because it will produce withdrawal. Yes. Okay, next slide. Yes, pregnant women. So again, a lot of the pregnant women that we end up seeing already have an OB or already have primary care, and they're referred to us as we are outpatient, stable enough to be an outpatient. So this is just some general information. We are admitting pregnant patients who are opioid use disorder patients the next business day. We've had, I want to say, less probably this year in 2022 than, I'm not sure why, but that in the last, I don't know, 19 or so years, pregnant coming in with opioid use disorder. Okay, the next slide. So here is everybody's information that's, physician-wise in our clinics. So the 885-5400 number, that's just the general number. If somebody needs a physician consult, that is where I would start. And then one of the doctors can talk to you. I can also have a discussion about referral and kind of what's appropriate. Yes, and right now it's Christmas time, I know, or it's holiday time. We are pretty fully staffed now, physician-wise. We do have less counselors than is ideal for us, but the medical piece, we also have I think we're okay on nursing right now too. So staffing for medical stuff is stable at our clinics right now. So I don't know if anybody has any questions or if there's anything else. Anything else that I can answer?
So maybe now we could, I know, Mike, you had a raised hand earlier. We can take your one question and then go to the scenarios.
Thank you. As an outreach worker, if I come across a female that is pregnant out in an encampment and they are refusing to get service or to get help, is there anything that we can do to, I don't want to use the word force, but encourage them to get the help they need? Or do we just have to turn a blind eye and give them the resources we have and say, have a nice day?
Well, I think you continue to encourage the patient to get care for the pregnancy. I don't think it's ever a dead topic. Just, I mean, there's many patients that enter treatment and do not want to be assessed for psychiatric medications, and 6 months or a year later, they may, agree to it. Obviously, with pregnancy, you have a shorter timeline, but I just think it, they're going to have a medical complication if they don't at least get some care for the pregnancy. And it's not going to be a pleasant experience in the hospital, which they will probably need to go to at some point. So I think you just, continue to support and encourage care. Obviously, you can't make the person go.
Right.
But I think, you're supporting the healthy part of them.
And
Right,
the
which
other
is
thing
there.
that we know, I'm sorry, Laura, go
No,
ahead.
go ahead. No, go ahead.
The other thing that we know is getting a woman into treatment when she's pregnant.
Mhm.
That if she did end up having any police contact or if she goes into the hospital and that baby is born under the influence, Child Protective Services could get involved. But a woman that is pregnant that goes into treatment, there's less likely of higher involvement. The research shows that there's less likely of higher involvement in the court system and in the CPS system. And that's one thing that I've used with pregnant women, just to say, hey, and actually, if they get into Parisi House on the Hill, I think Parisi House on the Hill is merging with Momentum now, so I'm not sure if that's still the name that they're using. But if they get in there, and they have a baby that is born toxic free, CPS is less likely to get involved. They might not even have an informal case. So we really use that to encourage women. I think women are really afraid that if they go to their OB-GYNs, that they'll report them or something if they're using. But OB-GYNs generally are doing referrals. They're doing brief intervention and screening to get the women into treatment, at least in Santa Clara County. And I only know this because I'm out at Mariposa, and sometimes we'll get a pregnant client that's waiting to get into Parisi, or they don't realize that they can refer to Parisi. So we don't turn them away. Obviously, we treat pregnant women, but we know that the benefits are better because they can have their child up there at Parisi after the baby's born. So we just work with them at Pathway at Mariposa and then refer them up there. But that's always something that I think is really good to share with pregnant women. Less likely involvement in the system.
This comes from a personal experience with a good friend of mine. The outcome was not good at all, but I just want to know for future, what's the best way to handle that?
And there's a greater risk with mutation and problem, toxic babies, just all kinds of behavioral symptoms. So
okay, thank you.
Okay, so with the opioid question, if a patient relapses on opioids after using Vivitrol, will this cause? No. It will, if patient relapses, no. It should not. The patient can use past the Vivitrol, but it should not cause, I mean, it's dangerous, to do that. Somebody on Vivitrol is a motivated person because they're not using any opioids at all. Vivitrol is an antagonist. Precipitated withdrawal, you generally see that when somebody started on Suboxone and isn't in enough withdrawal. So I think starting, you're not going to have precipitated withdrawal with methadone. Suboxones or buprenorphine's a safer medication overall. I mean, I see more success with it, I would say. We do have patients on methadone many, many years. I would say as they get older, they need to look at the dose being reduced just because their metabolism changes. I mean, everybody knows as your body ages, things do change.
I've seen a lot of success also with Suboxone.
It's a clean drug, pretty clean drug, not a lot of side effects. Methadone has, I would say has more stigma too, unfortunately, but yeah.
And having had a past patient that somebody consulted me on that was on Suboxone and restarted using fentanyl,
Mhm.
the client actually had access to fentanyl strips to test the fentanyl and stopped using the Suboxone. So the call came in to myself and the doctor, would there be precipitated withdrawal to start the Suboxone? No, it would only if they didn't get enough of the Suboxone. So we sent them to the hospital, and what the hospital did was start the Suboxone again and watched the patient just to make sure that the client didn't go into that, and gave them a fairly good dose. I think it ended up being over the course of the day 32. But
Yeah,
anyway,
30, yeah.
Yeah, it was about 32, and the client was fine, and the client got back in treatment and is sober again. So, you know, there's a lot of hope. That just so everybody understands why you might hear a lot about medication assisted treatment is that's the state of California is going that way. There was a behavioral health information notice that was sent out saying that all substance use treatment providers must either offer medication assisted treatment or offer referral to medication assisted treatment. We are audited to that now.
Yeah.
So because they're seeing a lot of benefits from Vivitrol and Suboxone and methadone.
Do we have any other questions?
Xenia made a comment and she's absolutely correct. It says California Bridge has more information as well. That's absolutely correct. Well, Laura could speak to this. NTP got highly involved with the Bridge program and received quite a few grant monies from that. And that's how, I mean, I know this because I'm so old. I remember when I used to work in the jail, and I would be holding the buckets as people were coming off the methadone because they did not have methadone. And I was one of those, Michael would love this about me. I was one of those lobbyists that said, why are we doing this? It's so easy. You've got a contained environment. You have a medical unit. You've got a pharmacy. You can just continue the methadone right here daily. And it's monitored, right? You're in jail. So now that finally happens, thanks to the Bridge program and other grant funding. But yes, you can look up that, and Santa Clara County has several grants from the Bridge program.
And at this, we used to only maintain pregnant patients on methadone in jail. Now we are able to maintain pretty much anybody that is appropriate. So, which is most people. So then in other words, they're not put on a forced taper, and then they don't have to go through a reinduction with us when they get out of jail. They're just maintained in jail. It's our medication. And then when they are released, they just come back to the clinic, and there's not any issues. I mean, they're still our patient is what I'm saying.
I have a
Okay.
question. Can I ask real quick? Can you
Yeah.
guys hear me?
Yeah,
Okay.
yeah.
Instead of typing it, sorry. A client recently got in touch with me that is currently in jail and he's receiving Suboxone, and he was asking how he would continue that upon his release. Would that be through reentry? Would the jail set him up?
Is he
The
a Santa
jail,
Clara,
oh, go ahead. You want to answer, Laura?
okay, is he a Santa Clara County resident?
To my knowledge, yeah.
So reentry can pick him up or we can.
Okay, so he would, prior to his release,
They will refer him. Yes.
okay, cool, thank you.
Yeah, he
They will
should
even
not.
let him call Gateway
Yeah.
from the jail. They will let him call Gateway from the jail to request that service.
Yeah,
Okay.
he should not end up being out of medication. You know, usually, I mean, he'd have to be assessed. If he's not our patient, he'd have to be assessed by us, but he's already on, right? He's already on the medication. So,
Yes.
yeah, so that would be, I mean, ideally, he'd be released on a weekday and we could see him.
And when you say we, do you mean like, where would he go directly from leaving Elmwood to you guys?
Well, he'd have he'd come the next business day to either Enborg, wherever he's going to live. So either Enborg or Alexian or South County. There's 3 options.
Okay, thank you.
And people are noting the reentry information and that there are teams inside the jail. Yes,
Yeah.
there are teams that are inside the jail that will make the referral. And they should already be doing that since he's on or she is on the Suboxone. However, when they're released, they will give them a bridge and then they will tell them to go to the reentry. That's normally what they've been doing.
Mhm.
Okay, here's, somebody has a question. Is it, oh wait, they're going too fast. I don't.
I can read. Is it
Okay.
possible for a client to quit meth cold turkey without substance use treatment and with no withdrawal symptoms? I have a client who I believe may be having slight withdrawal symptoms and states they're not using anymore.
It depends on how much they were using.
Yes, it depends on how much they were using, what they were using, if they were using methamphetamine and they didn't know it, what the meth's cut with. There's a whole bunch of different responses to that.
Yeah.
But depending on how much, what the pattern of use is, how long, all of that, and depending upon the symptoms of when they're under the influence. So if they are extremely happy, and they've been using for a long time, they might come off and they become extremely agitated or very depressed.
Yeah.
So there's a number of different symptoms that they could, but it'd be nice if they had some social support, at least if they're coming off the med, to understand that. But yeah, some people just decide they don't want to go into treatment, and that's fine too, as long as they understand that there's social support out there. People come into, just so you know, people come in that want to stop meth use. They come into our withdrawal management program, and they're there from anywhere from 3 to 7, sometimes even 14 days. They decide not to go into treatment and they stop.
Yeah.
They stop meth use.
Well, and we also have that, you know, with illicit opioid use. Sometimes patients are able to stop once we start them on methadone or bupe. They don't need a higher level of care. Sometimes if they have other drugs in the mix, they have a really hard time stopping those. And methadone or Suboxone are not going to ever treat methamphetamine use. So there's stuff coming out of UCLA now. There's other medications that I think they're looking at to treat cocaine and methamphetamine dependence. But there's nothing that's approved yet by the FDA. So,
However, there is, the state did
yeah.
approve and the governor did sign for what they call contingency management.
Yeah.
There are 2 agencies that are going to be part of that pilot project that I know of. I know one because I work for one of them, in their outpatient programs. The contingency management program, you can actually go to DHCS website and look up contingency management, and you will see it is a wonderfully outlined program where they are going to do, they'll have a coordinator for each of the providers. We hope we get a 3rd outpatient provider that's interested in doing this. And there are various contingencies that the clients receive because this has been a program that was monitored with the veterans in San Francisco, and they had some very promising results. And then, yes, there are some cursory studies for methamphetamine and cocaine use that Laura's referring to, but nothing that is FDA approved. And the studies are still cursory, but I'm glad they're looking at it because at least in Santa Clara County, that's what we're seeing still. Methamphetamine and alcohol is the top two substances. Although I do have to admit, fentanyl's starting to get up there.
Yeah.
There's a question on if the MAC clinics are providing Sublocade yet for youth patients, and if that would work for a pregnant
Oh.
patient.
Wait, if what will work for pregnant patients?
Sublocade.
I don't see them putting Sublocade in a pregnant person or somebody under 18. Not sure why you would do that. We do have a youth program that prescribes Suboxone. But somebody pregnant, they've already got a medical condition with the pregnancy. I don't see anybody doing that. Same thing with psych meds during pregnancy. A lot of providers won't do it.
So we are at our last minute of the training. So I just want to wrap up with a couple of reminders that one, the recording and the training material and both of our presenters' contact information will be shared by email after the training. Really with that contact information in particular, that's not meant to be directly shared with clients, but as a staff resource. So that is available to you if you have follow-up questions for either Laura or Tiana. I just want to thank you both for presenting today and covering such important material with us. And just as a final reminder, oh no, that's the wrong thing. You can ignore the chat. I wanted to save all the resources to share in an email. I will share the feedback form one more time for folks. I really hope you can take the time. It's pretty quick just to fill it out because I promise we look at every single one of them, and it really just helps us bring to you all the trainings you want to see, cover the content you want. But thank you all for attending today, and thank you once again to Laura and Tiana.